Estrogen. Is it a friend? Is it a foe? Is it just a bitch? Today, my guest was not able to join us. We will be having her back on. So you have me talking about the good and bad of estrogen and really looking into the research and the study and how it affects our thyroid, good and bad, and what the overall effects and the symptoms that you might be experiencing with high or low estrogen. So let's just start off. Estrogen needs to be vindicated. Estrogen is vilified in our society way too much. And this came from the reason why it was vilified in the very beginning. This came from the Women's Health Initiative study. When those results were released, everyone was stunted with fear, and women everywhere stopped their hormone replacement therapy because they heard and read and were scared by their doctors who pulled all of their estrogen away from them. Rightly so, but we'll get into that, because of fear of increased risk of breast cancer. So if we look at the actual Women's Health Initiative study, and there's a doctor, his name is Dr. Rowan Chablowski, and he has the Lindquist Institute. He's an investigator. He has multiple papers, multiple research papers on the effect long-term influence of estrogen plus progestin and estrogen alone, the use on breast cancer. The Women's Health Initiative used randomized trials. And the problem with the Women's Health Initiative is that it used randomized trials examining the risk of breast cancer in hormone treatment for postmenopausal women, but they used the fake stuff. Now, we've talked in other podcasts about birth control and birth control's effect on the thyroid and how it literally is an endocrine disruptor. Synthetic hormones like those in birth control are endocrine disruptors. Now, when we're talking about real bioidentical hormones, that is a whole other topic, and we're going to get to that. The Women's Health Initiative used synthetic hormones, and that's why we found, oh my God, look at this. There's an increased risk of breast cancer. There's an increased risk of blood clot and stroke. And that's why the estrogen was pulled away from women right out of their hands because of this fear. And we do kind of live in fear-based medicine, don't we, right now in this day and age? This fear prompted doctors to get rid of replacing hormones and then shut their mind down to any kind of hormonal replacement. They basically, were like those monkeys, like see no evil, hear no evil, speak no evil. We will not talk about estrogen anymore. It's bad, 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 bad. Estrogen dominance is bad. Synthetic estrogens are bad. And you have to look at studies from a point of view of really being a researcher yourself. You have to get into the data and really start to break it down and look at what it means for you individually and what that study actually means. Even the studies that we're seeing coming out today, the facts, the, let's say, fact checker information things that we're hearing today, you have to look at where is that source. Is it Pfizer? Is it a drug company? Is it the maker of synthetic estrogen telling you that it's good? Look at the source of your research, of the research that you're reading, not your research, the research that you're reading about, and see if there's any kind of influence. Even when we're talking about thyroid medication, Synthroid, right? The makers of Synthroid, what are they saying? Hey, doc, that T4 that we make is really, really effective. We think that you should prescribe Synthroid when you find that somebody has a thyroid condition, not any of those other medications. No. Armor, that doesn't work. No. T3, oh, come on. Our Synthroid is just as good as T3. Prescribe our Synthroid. Same thing with Bioidentical hormones versus synthetic hormones. Bioidentical is real. Anything that's real really can't be patented and can't be pushed into a pill unless it's from a compounding pharmacy. But then a drug company doesn't get that money, do they? Synthetic estrogens were prescribed ad nauseum back in the day because they were manufactured by a drug company, as are birth control pills to this day. But that is where we're finding the problem. So here's what we're looking at. When we're looking at Chabowski's study, he found that 2 types of treatment had the opposite effect on breast cancer. The postmenopausal women in the study using hormone therapy consisting of conjugated equine estrogen, CEE, alone, just estrogen, for about 7 years experienced a significant decrease in both the incidence of and mortality of breast cancer, with these effects persisting more than a decade after stopping use. However, those using a combination of CEE plus the fake progesterone, medroxyprogesterone acetate, MPA, a progesterone-containing hormone, but yet synthetic, if they used estrogen and fake progesterone for less than 6 years, they showed a significantly heightened risk of breast cancer incidence and associated mortality, also persisting for more than a decade after discontinuing use. So these findings from full-scale, double-blind, placebo-controlled, randomized clinical trials in conjunction with the previously reported effects on other clinical outcomes and consideration of patients' indication for treatment and personal preferences can now better form clinical decision making. And with these data, we now have the knowledge to meaningfully reduce the risk of breast cancer in postmenopausal women. We are using estrogen, bioidentical, real, not synthetic. We are using real bioidentical estrogen to now protect against breast cancer and in breast cancer treatment, post-breast cancer treatment. And I know this sounds very controversial to you, and this is kind of a controversial topic, but yet not in the functional space. Because in the functional space, we are here to calm down your fears. We are here to say estrogen is okay. I can't tell you the amount of women that I talk to that might be a patient. We chat about this on the phone before they sign up. Women who do become a patient who are still fearful of estrogen. So let's break down the good part of estrogen, right? So we know that estrogen is breast protective. It is also neuroprotective. It actually protects our brain against those diseases of aging. So Alzheimer's, dementia, Parkinson's, our brain needs estrogen, and it needs it in the proper amounts because our bodies, if you look back at the lifespan of a human being, at the lifespan of a woman 100 years ago, most women didn't hit menopause because they died of whatever, being out in the wilderness or polio or whatever the heck was killing them back then, starvation. Nowadays, we are living longer. Most women do enter menopause. It's something that you just can't escape unless you're working with someone that's actually replacing your hormones. So when we're looking at estrogen, we have to look at the benefits of estrogen and not be scared. Estrogen can actually protect against breast cancer, and we're using hormone replacement therapy, and that is estrogen, progesterone, and testosterone, because testosterone has great proliferative effects post breast cancer to actually prevent the recurrence and to help a woman just simply feel better, because 9 times out of 10, a woman is placed on tamoxifen to decrease their estrogen post breast cancer therapy, whether it's chemotherapy, radiation. And that's to lower her total estrogen and to block the bad estrogen. But over a period of time, and after she gets past that, which it should be short-term use of tamoxifen, she can then actually begin replacing hormones with bioidentical hormone replacement therapy, real estrogen, real progesterone, compounded testosterone, to help her feel better and to reduce the recurrence. So estrogen has multiple good benefits to it. It's also vaginally lubricating. So those of us, I'm not there yet. I can't say us. I'm still getting my period. I celebrate every single month. Those that have progressed into menopause, you may be experiencing vaginal dryness. The beauty of estrogen, estradiol, the good estrogen, the good witch, the witch that wears the white. Let's not demonize estrogen. There's the bad estrogen. There's the bad witch. What was she? From the east, from the west? The bad witch that wears the black. And then we have the good witch that speaks really with a high voice, and she wears white and she looks like a fairy princess. The good estrogen is there to make us feel like a princess, to give us the vaginal lubrication, to soften our skin, to actually help with collagen production. You've heard of hyaluronic acid. That's what they inject into your face and filler. Estrogen actually increases your natural hyaluronic acid and your natural collagen production. That's why when you lose estrogen and you go into menopause, your face starts to lose that plumpness, that plump look. The skin starts to get really dry, and that's where we see wrinkles. And that is a decrease in estrogen. I talked to a woman today who is experiencing hair loss. And yes, part of that hair loss is thyroid related because she's not yet optimized, but she also had a hysterectomy. So those of you out there who have had a hysterectomy, especially where your ovaries were removed, you just lost your ability to produce estrogen. Most of it. Some is produced in the adrenal glands, but most of your estrogen is produced in your ovaries. When we have a hysterectomy and we take that out, we have now lost all of our estrogen. And that's where you start to see the decline in hair follicle strength and thickness. So most women entering menopause will notice hair thinning. And that is low estrogen. And then when hair falls out, yes, that can be estrogen as well, but that can also be a combination of thyroid and estrogen. So that's where we really get hit with a double whammy with our hair, because the hair begins to thin because of low estrogen, and then it falls out if your thyroid's not optimized. So you want to make sure that both are happening there. Then when we're talking about skin, like I said, increased wrinkles, increased vaginal dryness, and then we start to get the brain fog. Y'all know that's tied to thyroid. Y'all know the brain fog and memory loss and that lack of concentration, definitely tied to low thyroid or non-optimized thyroid. But what if you have low estrogen on top of that? Now you have that double whammy. How many patients of mine tell me they think they're entering early Alzheimer's, and they're not, but they believe that they're entering a stage of early Alzheimer's because their brain just isn't functioning. And then we look at the labs and we go, look, your estrogen is in the tank. You're less than 15. And then let's not even talk about progesterone and testosterone yet. Hang tight. Those are probably low too. And then here's your thyroid, and that's in the tank too. So of course your brain isn't going to work, because your brain wants estrogen and your brain has receptor sites on it for T3. You're not feeding it anything, meaning T3 or estrogen. So it's not going to fire properly. You're surviving, but you're not thriving. Now, do we want estrogen in a dominant state? So let's go over estrogen dominance. So we talked about low estrogen. Well, real quick, before we go into, I think it would be worth going over some of the symptoms that are connected to low estrogen. So we talked a little bit about vaginal dryness, bad skin, hair loss. We know all that. We can also, the memory loss, the focus, the concentration, all that goes down. Our brain starts to work a lot slower. We can't focus. We can't think. We're not as sharp. A lot of our tissues start to dry out. So you might even notice dry eyes, dry mucous membranes. You definitely notice dry skin. I get that. And then we start to notice that our fire just isn't there. Not just sex drive, because that's more testosterone, but estrogen does play a role. But we start to know that fire, that desire to do things. I always call testosterone the get shit done hormone, and it is. But estrogen is right there helping. It's because it's very, very protective of our body. And it says, girlfriend, you need a little bit of me to even want to have sex with that guy over there, or that girl, whatever your preference. You need a little bit of me to have that desire. You need testosterone helping you out too. And testosterone is going to come along, and that's going to really kind of give you that drive and that motivation and give you that tingly feeling down below. But I'm going to be there helping the situation out, because there's no way you're going to have sex with a dry vagina. Sorry, this might have to be marked as explicit now because I said the V word, but it's true. Estrogen is there helping you be a woman. It's helping you be soft and supple. And I don't care if you're going into your 60s and 70s. Don't you dare tell me that you're all dried out and frail and wrinkly. You can be soft and supple. You can have full breasts. You can be breast protective against breast cancer with estrogen. So estrogen gets very vilified, and we will talk about the negative effects of high estrogen because we don't want that either. We want estrogen right in the middle. I always call iodine the Goldilocks hormone, or the Goldilocks, not hormone, the Goldilocks element. Estrogen is the Goldilocks hormone. See, with testosterone, we can go too high. We can actually increase someone's testosterone, a woman's testosterone, into the hundreds, and she feels good. And it'll be marked high on a blood test. But she tells me, listen, girl, you do not drop my testosterone below 100 because this is where I feel my best, and I'm strong, and I build a muscle, and I'm burning fat, and I have a libido. Fine. That's fine. Testosterone can go up above that reference range, and it's okay. We can actually deal with it. It doesn't come with a whole lot of negative side effects unless you start pushing into kind of the androgenic side effects of acne. Progesterone is the balancing hormone. You really can't go too high in that either. It's really hard to go too high in progesterone. Good luck doing that. I mean, again, unless you're with a doctor that has no idea what they're doing and they're putting you on 400 milligrams of progesterone, not realizing that you shouldn't be taking that much orally. I just talked to a person today. If you're listening, you know who you are. Your doctor should not put you on 400 milligrams of testosterone orally. That's ridiculous. Either the compounding pharmacy is messing up or your doctor is messing up. Somebody's messing up along the way. Very, very hard to get too high of a level of progesterone. Too high of a level of estrogen comes with problems. Estrogen dominance that we normally see early on. But listen, ladies, you can be estrogen dominant into your menopause years, and I will explain why. Estrogen dominance interferes with your thyroid function. That's why women get more thyroid problems in the first place, because we have more estrogen. So estrogen dominance actually pushes that T4 into reverse T3, and it puts you in that survival mode. We don't want high reverse T3. That will shut down your body's metabolism. With estrogen dominance, we already get increased water retention. Why in the hell would we want to shut down our thyroid function too? Talk about a double whammy. Again, when you want to talk about a double whammy with weight gain, go ahead and let's go into a state of estrogen dominance and not have our thyroid fixed and walk around with elevated reverse T3. That's probably caused by the estrogen dominance. So estrogen dominance over here, we'll call it ED, not to be confused with erectile dysfunction. ED over here is going to cause excess water retention. It's going to cause weight gain. It's going to cause irregular cycles. It's going to push up reverse T3. It is going to, if you do walk around with estrogen dominance long enough and it's not addressed, can it, even though it's natural, right? Even though it's your own estrogen, can it increase your risk of breast cancer? Yes, it can. Because most likely, if you are in a true state of estrogen dominance, and let's say it's not from polycystic ovarian syndrome, even if it is, again, we have to address that. And even if it is, you were probably stuck on birth control pills, which is exacerbating the whole situation. A state of true estrogen dominance, where your estrogen level, when we test it, and we break down and we test estradiol and estrone, the two types of, there's 3 types of estrogen, but we want to test those 2, estradiol and estrone. When we look at that and you are actually flagged high, you are actually coming up as red, you have a little H next to your estrogen level. That is a state of estrogen dominance. And the question becomes, is that from xenoestrogens? Is that from exposure to estrogens in your environment that is pushing you into an estrogen dominant state, or is your body just making too much? Now, hang with me. I know this is a lot of information. I'm going to break it down in steps for you. If your progesterone is low, and ladies, you can see low progesterone in your 20s. I have had patients with progesterone in the toilet, literally that little less than symbol, less than 0.3, less than 0.5. If your progesterone is low, then you are estrogen dominant if it's outside of a 1-to-10 ratio. What do I mean by that? So let's say we test your progesterone and you're 35, 40, and your progesterone comes back at a 1, and your estrogen is 250. Now, maybe it wasn't flagged. Maybe you were in the luteal phase where it came in within normal limits, WNL, within normal limits, within that standard lab value test range. But when we do the ratio, and your progesterone wasn't even flagged low, right? Because per the standard lab value test range, it's fine too. But when we look at that from a functional perspective and we say your progesterone is low, it's a 1, and that estrogen is way outside of a 1-to-10 ratio with progesterone, you are in an estrogen dominant state. I have said this before on other podcasts, but it's definitely worth saying again, because I know many of you ask me, what's the optimal value for progesterone and estrogen? There is no number I can give you, like I can give you with TSH below a 2. There is no number. It's about that ratio, and it's about how you feel too. So if progesterone is the balancing, calming hormone, and that is low, and estrogen is high, you're going to feel on edge. And it's not necessarily that you have too much estrogen, it's that you don't have enough progesterone. So what do we do in that case? We give you progesterone. We don't have to give anything to lower estrogen unless it's way outside the norm, unless you're really estrogen dominant. Then we can use something like DIM or calcium D-glucarate. But we give you more progesterone. We don't want to lower the estrogen too much, because another factor, by the way, of low estrogen is anxiety and weight gain around the middle. Now, you might experience weight gain overall. So again, I have another patient today. We're kind of going back and forth, trying to figure it all out. And this is where, ladies, sometimes it's not your thyroid. I have another podcast called Sometimes It's Not Your Thyroid. Sometimes it's not your thyroid. Sometimes you really do have to look at your hormones if you are gaining weight, or if you are anxious, if you are feeling on edge. Because if we look at your thyroid and your thyroid looks pretty damn good, and we look over here and your estrogen's in the tank, you are going to be anxious and you will gain weight as well. Our goal is not to lower your estrogen to 0. Our goal is to get you optimized across the board. So if that means giving you a little bit of progesterone and giving you estrogen, then so be it. When you are taking estrogen replacement therapy, and I don't care who you are working with, I want you to listen. Estrogen should never be unopposed, meaning you need to have progesterone in the mix too. It is incredibly rare that we see low estrogen where we would have to actually use a compounded estradiol cream or use something like Biest cream to raise your estrogen levels. We don't want to use that alone without using some type of progesterone, whether it be a cream or an oral form. Now, the oral form is great of progesterone because it turns it through the liver. It gets transformed into allopregnanolone, which is also very neuroprotective of the brain. And we can use a cream, or we can use oral and cream. So that patient I talked about earlier that was on 400 milligrams of progesterone, no. Maybe 200, and then add in some topical and do oral and topical together. For God's sake, go up to 400 milligrams of progesterone. So we address the progesterone with the estrogen. So estrogen should not be unopposed, meaning don't use it alone. Estrogen also is not great in the oral form. That's where we see a lot of issues. Progesterone can be metabolized by the liver very smoothly. And actually, we get benefits, like I just said, when it's metabolized by the liver. Testosterone, I mean, it kind of pounds the liver pretty hard when you take it in oral form. Testosterone really should be in an injectable or cream form. I know some of you are using pellets. That's going to raise your testosterone much too high. But testosterone tends to do better non-orally. Troches, I'm kind of on the fence about. Estrogen should be a cream-based. Cream-based. We don't want estrogen going through your liver. It's going to pound the hell out of it. So let's not do that. And as long as we're using the bioidentical form, ladies, you don't have to worry. The bioidentical cream form. You do not have to worry about an increased risk of breast cancer because it's actually protecting you. There was one study, if you really want to deep dive into this, I'm actually going to tell you to go to Dr. Lindsay Berkson's site. And she is a breast cancer survivor. She's a DES daughter and she's a breast cancer survivor. I want to say she had it like 16 years ago, something like that. Has been on hormone replacement therapy ever since. She is a researcher. I love her to death. Dr. Berkson, if you're listening, I want to have you on this podcast so you can give this information to my people because you say it way better than I do because you know this inside and out. But if you want more information, definitely check out Dr. Lindsay Berkson's podcast. So she references a study done. I couldn't tell you the researcher. If you are a postmenopausal woman and you use estrogen, bioidentical hormone replacement therapy, specifically estrogen and progesterone, for just 1 year, you protect yourself from, you have a greater overall protection from breast cancer. I want to say it's like a 50 to 60% increased protection, just 1 year. And that kind of goes along with what I referenced earlier, Dr. Chalowski, finding that if these women would use estrogen and real progesterone. Now, I know earlier you're going to say, you told me that estrogen shouldn't be unopposed. And this study used conjugated equine estrogen for 7 years, and people experienced a significant decrease in the incidence and mortality of breast cancer. I get it. But since then, we also have learned that estrogen is better when it's with progesterone, real progesterone, not fake progestin. Dr. Chalowski found, again, these women were using it for 7 years to experience the decrease in the incidence and mortality of breast cancer. The study that Lindsay Berkson references, it was 1 year's worth of use after menopause decreases your risk of breast cancer. That's huge. That is huge. Can you imagine if I could take all of you women and put you on bioidentical hormone replacement therapy? Now, would I want to use progesterone and testosterone too? Hell yeah. Because I want to give you that get shit done hormone. I want to give you a sex drive. I want to give you sexy lean muscle mass that comes from testosterone. I want to give you better sleep and calmness and a decrease in anxiety and depression that comes with progesterone. I want to give you that reduction in water retention that comes with progesterone use. But I also want to go over here and protect your breasts and protect your brain and give you a happy vagina and good skin and good hair that comes with estrogen. And if we do all of that and we optimize your thyroid at the same time, can you even imagine the life that you can experience in your 50s, 60s, and 70s? And what do I always say to you, specifically in relation to thyroid? But this goes across the board, thyroid and hormones. I always say that God did not make us. I know there's going to be a counter argument. I'll address that in a second. You hold your tongue. God did not make us to be fat, frustrated, and tired and bald. He made our bodies to thrive. Now, the counter argument, people are going to say, yes, but God gave us menopause. God made the human body to go through this state where we lose our periods and because he didn't want y'all having kids at 60. That's stupid. Am I wrong? Yes, there is that. We were made by God to go through menopause, but also we're all given a brain. And throughout the years, some of us have bigger brains than others. Those people figured out that there's a way to do this bioidentical hormone replacement therapy thing. And then when we go with Dr. T.S. Wiley, we even get deeper where she's saying, and I can give you a period into your 80s so that your body thinks that you're 20. And imagine the beauty that comes with that. Now, some of you are like, no, thanks. And I understand that. The total, what is it called? The T.S. Wiley approach of restorative, like total restoration of your hormones to be having a cycle every single month into your 80s is not for everyone. It doesn't appeal to everyone, but it does come with benefits. But quite frankly, whether you go that route or you go the route of just kind of minimal hormone replacement therapy to maybe you're not having a cycle every month post-menopause, but you're sure as hell feeling better, either way, I choose hormones. I choose hormones because I don't want to dry up and I don't want to get old. And I want to have protection against breast cancer. And I want to have protection against Alzheimer's because my mom had it and her dad had it. So I am going to do all of the things. Now, this is a road that I encourage you to do your own research on. Don't just go by this podcast, obviously. Listen to Lindsay Berkson. Get into the research on what bioidentical hormone replacement therapy actually is and what it can do and what the benefits are. Downsides? Haven't found any. I'm sure there are women out there that have been through breast cancer and are scared to death of anything containing the word E, estrogen. But I still would encourage you ladies to do some research because if used properly, estrogen can actually protect you from recurrence and can make your life a whole lot better. Because I know that tamoxifen pounded the hell out of your body and you're feeling really dry. You're feeling really dry right now. I encourage everyone to do their research and keep an open mind and push out what you've heard in the 70s, 80s, 90s, early 2000s about how hormones are bad and estrogen is bad. What we really should be focusing on is birth control pills are bad. That IUD you have in you is bad. Those two things that we all consider natural, because we're women and our doctors put us on the birth control and I had heavy periods and I had PCOS. So my doctor put me on birth control. That's what you should be questioning. That's what you should be taking out of your life. That is what is going to totally screw up your thyroid. That is what is going to put you at an increased risk of breast cancer. That's what's going to make you gain weight. Not the bioidentical. That's what's going to give you the blood clot and the stroke, not the bioidentical. Do your research before making a decision. And as you know, even with the thyroid, don't go by what your doctor says just because your doctor, it's the same doctor that told you your thyroid was normal too and within normal limits. And it's not. So that same doctor that said, Susie, you should not be using estrogen. You should not be using hormone replacement therapy because, the Women's Health Initiative showed that you'd have a stroke and you get breast cancer. That's the same doctor that's telling you your thyroid is normal too. So open mind, people, open mind. We had a lot of questions come in, so I want to get to those. And I think I always say other people's questions are your questions and other people's questions can help you, especially when you hear the answer. So hi, everyone that's listening. Donna, Key, Elaine, Linda, Helene, Mary, Susan. Love you guys for jumping in. Okay, I'm getting a lot of love yous. I love you back. Love you back. I'm using the AIM progesterone cream. I don't know what that is. Most of the time, progesterone creams, topicals, are micronized progesterone are the bioidentical form. Now, that being said, this is a great question. Let me touch on this. A while ago, and I don't know if it's still even looked on the shelves of a vitamin store, dietary food place, whatever. But back in the day, we used to have the wild yam. Remember the wild yam cream that you could get? So, gosh, there was wild yam. There was black cohosh, which does help with hot flashes, but I like using that and actual estrogen cream like Biest or compounded estradiol. For progesterone, there were those over-the-counter, not really progesterone, not micronized progesterone like there is now. Like Designs for Health, I always talk about Progestavail. Designs for Health has the micronized topical progesterone, and it's a serum. It's like a face serum, like a sticky face serum. And you put that on your thin skin areas like inner thighs, inner forearms, lower belly, and that absorbs and works just fine like the oral progesterone. And it works in conjunction with it. So again, we can use oral and topical together, especially if someone's progesterone level is not coming up like it should be. We can hit it from both sides. We can use the oral and the topical. But the AIM cream, honestly, I don't know what that is. I don't know if that is bioidentical or not. So I apologize, Linda. I'm not quite sure what that is, but I would encourage you to maybe either, obviously get tested. Test, don't guess. Test, don't guess. Get your hormones tested. If you're postmenopausal, it doesn't matter what time of the month you get it tested. If you are still cycling, we like to test hormones in that day, like 19 to 22, preferably 21 time frame to really get that accurate picture. And if you are using any kind of hormones, you need to stop that a couple days before so we can get that accurate picture as well. I would encourage you, Linda, to test, not to guess, and then to actually look into bioidentical creams. Look into the Designs for Health Progestavail, because we know that is micronized progesterone. So when we prescribe you progesterone, we're prescribing usually 100 milligrams of bioidentical micronized progesterone, cream, serum, pill, whatever it is. The Designs for Health Progestavail is one full dropper, 100 milligrams of micronized progesterone per milliliter. So when you use one full dropper, that's 1 milliliter, you're getting 100. It's just absorbing transdermally, and it doesn't get that liver pass to turn into allopregnanolone. But again, that's sometimes why we use both. Okay. Any thoughts on rhythmic dosing? Bam, Helene, you nailed it. That's what I was looking for. I came up with restorative. It's rhythmic. And one of my dear friends, Suzanne, is a pro at rhythmic dosing. I have taken some courses. I'm not quite all in yet, but I'm also not in menopause. So for me, I'm standing back here going, I'm not quite sure yet. And I have a thyroid. I don't know if I want that much estrogen yet, but I'm going to trust her when it comes to that. And we'll play around and we'll see. Yes. So Helene, any thoughts on rhythmic dosing of estrogen and progesterone, e.g. the Wiley protocol? I mentioned the Wiley protocol earlier. You know what? For some people, it's amazing. It's a game changer. It's a life changer. Women love it. And I might too, because like I said, I celebrate. Aren't we so real on this show here as we come together? I celebrate every month that I have a period. I'm like, woo, yeah, not in menopause yet. Now, I'm talking about a real cycle, like a real period. I know many of you are having like these spotty ones, like you get day 21 and day 28. Patient earlier today, hopefully you're listening. Day 21, day 28, it's very, very light. You look at the estrogen, it's in the tank. Estrogen's in the tank. She's feeling anxious, gaining weight. Thyroid's okay. T3, free T3 is a 4. I get it. Her optimal free T3 might be higher than a 4. Maybe she's a 5. Maybe she's a 6. But for all intents and purposes, let's look at it for what it's worth. Free T3 is a 4, reverse T3 is low, 9, 10. But the estrogen in the tank. Estrogen is in the tank. Spotty, period, light. Maybe 1 day, maybe 2, and then boop, done. Day 28, 21 days, 38 days. It's all over the place. Still cycling, but not that hardy. We'll call it hardy. Not that hardy of a cycle to where her body is actually ovulating. So ovulation has shut down. Estrogen's in the tank. Progesterone and testosterone are low. It's perimenopause, menopause. That's what's causing the weight gain. That's what's causing the anxiety too, because the low estrogen is going to cause anxiety. Low progesterone is going to cause anxiety and agitation. I always say, if you're low progesterone, if your family members go, what the hell's wrong with you? Like, why are you being so bitchy? So can estrogen be a bitch? Yeah. If it's dominant. Can it be a friend? Yeah. It's right in the middle and it's balanced and it's optimized. So it can be friend or foe. Rhythmic dosing, it's all how it jives with your body. I'm definitely not opposed to it, totally open to it. We just have to find what's going to be right for you. But I will say many, many women absolutely love rhythmic dosing. Takes a little bit more effort on your part. So if you're the type that goes, well, I can't even remember my second dose of T3, rhythmic dosing is not for you. Okay, let's just lay it out there. But if you're into this, you got the timer going for your second dose of T3 and you got all your supplements laid out and you know when you take it and when then I would give rhythmic dosing a try and just see how you feel. You can always back off. We can always back down your hormones. But that's probably where my first step is going to be, is in the rhythmic. And then I'm going to see how I feel, because I like plump skin. I'm really big into anti-aging. You guys know that about me already. I'm not, listen, I'm planning on being here in front of you at the age of 70, still with long hair, still fighting wrinkles, maybe a facelift or two behind, but I still need the plump skin. Facelift ain't going to give me good skin. So rhythmic dosing might be the way to go. Do you know what our estrogen, progesterone, testosterone levels should be? Right, lady. Okay, Miss Mary. After menopause, especially after partial hysterectomy, and you got to keep your ovaries. So there is no, again, Mary, there's no level I can tell you. I can tell you for testosterone, 40 or above. I don't want you below a 40 with testosterone, and that's your total testosterone. I want that 40 or above. And then we take into account if you're on testosterone replacement therapy or not. But there's not a number I can specifically give you for estrogen and progesterone. I just don't want them in the toilet. If you see a less than sign, that's a really big red flag, whether it's estrogen or progesterone. You never want to see less than. And I know on the standard lab value test for progesterone, where it says postmenopausal, your normal range, less than 0.5. But again, is that optimal? That's normal if you want to feel like garbage in menopause, but it's not optimal. It's just normal. Okay. Susan, you're saying you're postmenopausal. When you apply estrogen, the hair loss gets worse. And progesterone kicked up the hair loss too. Here's the thing, Susan. When we're talking about hair loss, hormones are not going to increase hair loss. Now, testosterone can convert to DHT, dihydrotestosterone, and that causes the male pattern baldness around the hairline. But it's very, very rare that I see elevated levels of DHT in anyone, even in men. It's very, very rare to have elevated DHT. We see elevated DHT in some men that are taking large doses of testosterone. So look at your bodybuilding population. The dudes that are using really high levels of test, high amounts of test, they're probably using injectable and oral. They will start to get, even 20-year-olds will start to get that male pattern baldness. You'll see the receding hairline start to go back. Now, if you are a woman and you're experiencing the receding hairline, we definitely want to test your DHT. We want to make sure that you're not converting testosterone over to dihydrotestosterone. If you do not have that type of hair loss, and it's just kind of an overall hair loss or even a hair thinning, we absolutely have to look at estrogen. I'm sorry, Susan, if that estrogen is low, that is going to contribute to hair thinning, hands down. We know that. But my other question for you would be, is your thyroid optimized? How's your ferritin level? How's your zinc level? How are your nutrients? All of those factor into hair loss. And it's most likely not that progesterone and estrogen caused your hair loss. It's more likely that your thyroid is not optimized, that your zinc is in the tank, that you might be low in your ferritin or anemic. Maybe you have low iodine levels. Those are bigger factors when it comes to hair loss. Those are the factors when it comes to hair loss, in addition to low estrogen. But I've never heard of using bioidentical, not synthetic, not fake. Make sure that you're using bioidentical estrogen and progesterone causing hair loss. It just flat out really doesn't happen. It does not happen. I mean, short of those hormones being synthetic, you're not going to see that. It's going to be another factor. Are you eating enough protein? Most of you ladies aren't, by the way. I'm pretty much at about 99% of all new patients when I look at their food and I add up the protein. You guys are maybe getting 50 to 60. You are not getting in enough protein. I'll do a separate episode on protein, I promise. You're not getting in enough protein. You better get minimum of 80 grams of protein if you are experiencing hair loss. And if you're not, you cannot blame anything else. You cannot. Yes, it can be your thyroid off too. But if you're not getting 80 grams of protein, if you're not getting those essential amino acids that your hair desperately wants and needs, of course you're going to experience hair loss. And then when we actually start optimizing your thyroid and you notice increased hair loss, we're increasing your metabolism if you don't have the protein there to support the hair. If your estrogen is in the tank, if your zinc's in the tank, if you're anemic, then it's going to appear as if you're losing more hair. And that can happen even if everything is perfect and we put you on T3, hair growth cycle kind of speeds up a little bit so you can see a little bit more hair loss. But Susan and I would encourage you to check all of those other markers, because I would bet money it is not the estrogen and progesterone that you are using. All right, guys, a few other questions. I am 71, had breast cancer at 58. Oh, I see you, Annette. Yeah, you listened to me, didn't you? Nancy, I'm 71, had breast cancer at 58, then took aromatase inhibitor to shut off my estrogen and progesterone, since my cancer was positive for both. And then 12 years later, last year, my breast cancer came back. And again, it was estrogen ER/PR positive. I had to have a bilateral mastectomy. The whole topic of hormones scares me to death. It caused my cancer. I was also diagnosed with thyroid cancer during my CT scan for the breast cancer. I'm a hot mess. Nancy, look up Dr. Lindsay Berkson. Listen to all of her stuff. All of it. She has a podcast called, I want to say it's Estrogen's Vindication, because that's where I think I got that term from. She has a whole lot on estrogen. Look up her stuff. She is a breast cancer survivor. She digs deep into this topic. I know hormones scare you. The synthetics should scare you. Xenoestrogen should scare you. I don't ever want to see you microwaving your food in plastic. You got to be using a stainless steel water bottle. No endocrine disruptors whatsoever. Get rid of the Bath and Body Works. No Glade plugins. For you, no candles. None. No fragrance. No perfumes. No garbage. No sulfates, parabens. No grains because they're sprayed with glyphosate. I will be having Anthony J on my podcast soon, and we are going to be talking about estrogeneration, his book, and all the different sources of estrogen. No lavender oil, Nancy. Lavender essential oil increases estrogen. It's a xenoestrogen. I know you hate to hear that because you love your lavender. But there are things that you can do to avoid the xenoestrogens in the world. to protect yourself from excess estrogen. But I am betting money again, Nancy, that you could use, and maybe not the Wiley protocol, maybe not rhythmic cycling, rhythmic dosing, but you could use and benefit from a small amount of estrogen, but you need to get with somebody who knows what the hell they're doing in that area. I want you to do some research on your own so that you feel comfortable with it too. Many people love their bioidentical hormones, just like Debbie. I get it. I get it. Alicia says, I was prescribed progesterone capsules from manufacturer Aurobindo. How do I know if it's bioidentical? I don't know. I don't know, Alicia. I guess my advice to you would be to call the pharmacy, because wherever that pharmacy gets it, and I could run in and get my micronized, I couldn't tell you the manufacturer of my micronized progesterone capsules either. But yeah, call the pharmacy and say, I'm just double checking. This is micronized progesterone, right? Micronized bioidentical progesterone. Or look up that manufacturer online. See if they have any kind of information online that you could grab as well. Okay, Susan, we're back to you. I'm seeing an endocrinologist next Monday and a postmenopausal total hysterectomy. That's why you need the progesterone and the estrogen. Estrogen makes me feel like I'm on steroids, so I can only use a smidge, then lowered progesterone because it made me cry. Then once lowered, my hair fell out. What test can I ask for? So first of all, if you're seeing an endocrinologist, you know where I'm going with this, don't you? If you're seeing an endocrinologist, so Susan, I have been in practice for 26 years. I say this a lot on my podcast, so everybody is going to be able to repeat this after a while. I have patients in the US, Canada, the UK, Australia, South America, Netherlands, New Zealand, and I'm probably missing a few. In all of that time, in all of those countries, I have on my list of good endos 3. It might have even been cut down to 2 recently, but 3. You are not going to, endocrinologists do not know the thyroid. Endocrinologists do not know hormones. And again, Susan, I would bet money that you were on synthetic and that no one knew how to dose you. Estrogen should not make you feel like you're on steroids. I don't know the type, I don't know the dose, but somebody screwed up along the way. And I am betting money that it was a doctor you were seeing that was using the wrong kind. God knows what they were using, but they were using the wrong kind. They were using synthetics, or they just simply weren't knowledgeable enough in the dosing. Maybe you're on too much, maybe not enough. Progesterone should not make you cry. It should make you not cry. It's the calming, balancing hormone. Now, maybe the oral form doesn't work for you and you need the topical. That's okay. You can find what actually is going to work for you and for your body. But I promise you, bioidentical estrogen and progesterone don't cause hair loss. Bioidentical estrogen and progesterone do not cause you to cry. I mean, unless you're on way too much estrogen, then you might become a little bit weepy and emotional. But it should not do that. What tests can you ask for? And I will leave you with this. What tests can you ask for? There's so many good questions. I'll try to get in a couple more, but I'm going to have to run in a second. You want to ask for total estrogens, estradiol, esterone, progesterone, free and total testosterone, DHEA, pregnenolone, and for you, DHT, dihydrotestosterone, just to check it out, just to see. And of course, Susan, I would also recommend a full thyroid panel, TSH, free T3, free T4, reverse T3, TPO, and TGA antibodies. Now, I do have a free download on my website that you can go to get the thyroid labs. It's the lab and symptom checklist. So at least you'll know the optimal lab values for those as well, and the thyroid tests. But the hormones ones, I just rattled off to you. Okay. Okay. And my progesterone. This is Christy. I got to do a couple more before I go. I got to do a couple more for you guys. So many good questions. Christy, my progesterone was tested on day 21. It was way below the normal line. FSH tested on day 3. It was also below the normal line. Yeah, your progesterone is low. You need progesterone replacement. Follicle stimulating hormone, FSH, that stimulates the follicle to release an egg. So if FSH was low, you're most likely going into perimenopause, menopause. Okay. Kat, you tried progesterone the past 3 times, felt terrible. Is there an alternative? Again, we don't know if you were on the micronized form. We don't know if you took oral. We don't know if you took topical. We don't know what your number was. We don't know how you took it. We don't know if it was synthetic. So all of those things that we said before there, Kat, I want you to look into. Make sure it wasn't synthetic. Make sure it was micronized. Make sure it was bioidentical. What was your dose? Were they giving you too much? Were they giving you 400 milligrams? That's not good. It's not good. I just have no words for that. I have no words. Okay. Dr. Lindsay Berkson, Nancy. So if anybody wants to miss something, listen to this tomorrow. It will come out as a podcast on the Thyroid Fixer podcast. I highly encourage all of you to subscribe to my podcast, to go to my YouTube channel and subscribe there as well. That way you get all the new stuff that comes out. We release podcasts twice a week. That's a ton of information, totally bingeable. And I promise you, it will load your brain with such good info. You will be a badass patient advocate for yourself. Badass. Kat, you're on topical and natural. Girl, I would try the oral then. I would start off with 50 milligrams, micronized oral progesterone. And I would see how you tolerate that, because quite honestly, maybe the topical just didn't quite cut it. Anytime we use a topical transdermal cream, does it absorb? Yes. We got to put it in the thin skin areas. But you have to really make sure, it's absorbed, and then you're not getting in the bed and touching things, and that you didn't put on clothes after you put it on, and then that's rubbing on your clothes. So you might not have been on a high enough dose of the topical. It might not have absorbed well. You might need to try the oral. Last question. Marissa, do you recommend the Dutch hormone test? Beautiful question, girl. Okay. When you ask functional practitioners about the Dutch, you will find split down the middle. I have heard arguments on both sides for the Dutch. I've heard the argument that the Dutch is dried urine, and how in the hell can we possibly get the right amount when we are using dried urine? Okay, I get that. I've also seen the Dutch test come out with some really cool information regarding the metabolism of estrogen and the metabolism of progesterone. And when we are looking at the Dutch test, it normally does line up with serum. So normally if I'm looking at someone's serum test, blood, and I'm looking at the Dutch test, I normally find a lot of things coincide. Like if testosterone's low, it's going to be low. But here's the thing. The Dutch test is dried urine. It's accurate. It tells you if you're properly methylating. It's really, really good for measuring progesterone, although the serum gets a pretty darn good accurate read too. But you can't use the Dutch if you're taking oral estrogen. You shouldn't be taking oral estrogen anyways. And the reading of the testosterone levels can be skewed. And then if you're using a transdermal cream, that can pose an issue. And you cannot use the Dutch to dose bioidentical hormones. Got to use serum. Urine will capture all day hormones. And that's good. Urine, that dried urine that is the Dutch test, the results can be skewed because of that first pass metabolism. So when we're catching dried urine, it's already done a first pass through the liver. It's already been metabolized. And I get it. The proponents of Dutch are like, well, that's what we want to see. We want to see the metabolized hormones. And it does measure the metabolites of estrogen, but it can just, if you're taking oral hormones, if you're taking transdermal hormones, it can really start to skew the results on the Dutch. I mean, that is really why I like blood. It measures the bioavailable and the non-bioavailable of those hormones. It's a direct measure of what's in the body at that time. It's extremely accurate. I think it's the best tool for bioidentical dosing of hormones. This is blood. Now, the downside is it provides only a snapshot in time. It doesn't account for the rising and falling of hormones, and it can't test for metabolites. So, with the Dutch, that's a next step thing. That's a let's start with your blood. Let's start with your serum. And then if we need to go deeper, we can go into the Dutch. All right, ladies, I hope you got a ton of information. Ladies, gentlemen, I know I left the guys out. This is really a topic for women today. I will see you all next week. And again, subscribe to the Thyroid Fixer podcast. Subscribe on YouTube as well. Love your questions. Love the input today. And I will see you all soon.